It's time to turn down the noise and tune in to News You Can Use, the show that gives you a quick insight into the latest twists and turns in healthcare news, where every diagnosis comes with an order of side-splitting humor. Your hosts are Dr. Nick, a longtime host, innovator, and healthcare wizard who can prescribe a digital dose of innovation to cure even the most ailing operational inefficiencies. And Dr. Craig Joseph, the healthcare guru who can diagnose both patient and software glitches with equal precision, making sure hospitals run smoother than a well-oiled robot doc. So buckle up, because we're diving into the ER of excitement, the ICU of irrationality, and the waiting room of wacky wisdom. Now here's Dr. Nick and Dr. Craig.
Welcome to the month of January. I'm Dr. Nick.
I'm Dr. Craig.
This week, we'll be dissecting the latest healthcare news, unraveling the twists and turns, and making sense of all of the debacles.
Just remember, life's a lot like a breaking news story. Unpredictable, often absurd, and occasionally leaves you wondering if it's all just a cosmic prank.
This week, we take a look at COVID, back in the news, and its long-term effects.
And we dive into GLP-1 agonists and whole body scans.
But first off, this week, we're going to talk about physician assistants and the assistant sort of expansion in the healthcare setting, and specifically what's happening in my original training area, the United Kingdom and the NHS.
Wait a second. Can I stop you right there?
Oh, of course you can.
Are you saying that you're not originally from the United States?
You mean you can't tell from my Southern Alabama accent?
Yeah, I mean, I thought that's how they talk in Virginia, but apparently you're from the UK, so I have to reassess everything now.
I have to tell you, it's a little bit of a mix, because I got into an awful lot of trouble last week when I was staying at the Renaissance Hotel, and I was told that's not the way you pronounce that.
It is not. It is not. No one would pronounce it that way.
Well, just to be clear, they do. And I thought it was a British thing, but when I got home to sort of validate this with at least some, insights from that country, I think it's my French influence that's causing that, because that's how the French would pronounce it. So it is the Renaissance. I'm not moving on this.
That's fine. You can be wrong and consistent.
And mostly this is true. So let's talk about these physician associates. So they've been around for a while. I mean, I think here in the US, that group has been here for an extended period of time. Did you have them during your sort of time practicing and in medical school, or have they shown up since?
No, they have definitely been around. I think from a physician assistant standpoint, I think a lot of it started after Vietnam. I remember reading this, and so don't quote me if I'm wrong here, but a lot of GIs came back from Vietnam with very advanced medical training, but absolutely no degree, and they were doing kind of minor surgeries out in the field, and then they came back to the United States and had really no way to leverage all of those skills and knowledge that they had unfortunately had to process. And so I think the PA program kind of started from there. But yeah, even when I was a resident, I remember one of my first surgeries where I was in the operating room. They were doing a coronary artery bypass graft, a CABG, and there was some dude. When we were opening up the chest at the top of the patient, there was some dude in the patient's leg harvesting a vein, and I asked who that was, and I was told that's the PA. And so, yeah, they've been that position and has been around for a long time in the United States.
Yeah, it's interesting that you say. I had no idea it was that extended. I mean, it made a lot of sense. I do remember specifically that whole harvesting of the veins, and that caused immense resistance on the part of the cardiac surgeon who wanted to do that. But in reality, when you look at it in hindsight now, of course, having somebody super well trained to do that relieved them so that they could focus. And in fact, we take them from different places now. But that was a huge deal, but it made a lot of sense. And, this supporting act, I think, is absolutely essential. Extend the capabilities, have people doing those tasks. But here's what's going on in the UK. Recent article in the Telegraph. I would say many of the physicians in the United Kingdom are apoplectic over the extension of all this. It seems like there's an intent on the part of the government to create this two-tier system where if you don't have access, you get to see a physician assistant or somebody like that in a general practice. And we're even seeing them taking on call for what we would call registrars. So that's like a PGY4 or even a chief resident on liver transplant is taken. So nighttime call covered by a PA, which, folks are really troubled by it. And there's all of these examples of adverts saying, hey, couldn't get into medical school, go to PA school, and 18 months later you'll be practicing as a doctor, and many of them sort of posting notes that just raise this enormous question. And I watched all of this just troubled, because I love the supporting capabilities. And, I've often been heard to say that nurses were the saving grace for me as a junior doctor, certainly. And, we see that extended practice. My wife was a midwife who had prescribing rights essentially in the delivery of babies and, stitched and delivered, very different to the US. But where's the line? And how do we sort of manage this? And, my fundamental point, I don't know how you feel, but I struggle, even going in now to the physician's office, there's a procession of people who show up, never introduce themselves or their role. They just say, hi, I'm Joe or Jane, and start doing things. And I have no idea who they are. And I always ask, and they seem somewhat offended when I do, but it seems like there's trouble ahead, as we'd say, trouble ahead at mill.
Yeah, I don't know. I mean, I certainly have, I think, mixed opinions, as does everyone. It's a complicated issue. You have, if we broaden out this conversation, we're talking about physician extenders, I think is the term, right? And in the U.S., that's typically physician assistants, PAs, and nurse practitioners and nurse midwives, as you just referenced. And different. Obviously, well, not so obvious. There is no national license for physicians or nurses or PAs in the United States, right? And so,
wait, a second. This is important. When you say national, you mean a centralized single one?
I do. So, yeah, as and again, it seems obvious to me, but apparently I'm a physician, so I deal with this, and so normal people may not realize that. Just like your driver's license, you don't get a driver's license from the federal government. You get a driver's license from the state that you live in, and similarly, you get a medical license or a nursing license or whatever a PA needs, a PA license. From that state. And if you practice in 5 states, then you need to deal with 5 different licensing authorities.
Because we know that medicine is different in
it is.
one state from the other.
When you go from Michigan to Ohio, it's like,
oh my God,
you're on a different planet, of course. But they all, for fun, they all have their own.
Let's hope we've not offended anybody from either of those states.
No, I have a license to practice in the state of Michigan, and I suspect my practice patterns would be very similar in Ohio when I cross that line. and so. Every state has their own rules around what physician extenders can do. And you mentioned that your wife had prescribing authority, and that is the case in many states. However, where it starts to get a little dicey, and I think that's where you're seeing some of that in England, is practicing independently or not. Can a PA? It's one thing to. And the way I've seen it in doctors that I've visited is that there's a PA or a nurse practitioner, and in general, in an office setting, like they can handle most things. But there's always a physician either nearby or virtually available, so that if we run into something that's uncomfortable for them, or they don't have a lot of training in, that they can get a second opinion, and there's someone kind of who has their back, much like an intern or a resident. Is making decisions, but it has supervised attendings looking over their shoulders. And so where's that line? And I think the line is independence or not. Are these folks allowed to make decisions without anyone kind of second co-signing, or giving a second look?
I think based on what you've just described, the UK is definitely stepped over the line, because some of the examples that I've read of a physician assistant in the community, in a general practice office, seeing a patient with no oversight and referring to a hospital where that referral is seen by another physician assistant. That, for me, is way over the skis. And I think in the latest data study, there was an extraordinary number of missed diagnoses. I want to say it was like 170 that they identified tied to this. I mean, it seems like a real problem, and boy, do they need to fix that. But from my perspective, interesting that it's now sort of occurring and causing major problems in other countries. I think this isn't going to go away, and we do have to fix it. Let's move on, since otherwise we'll run out of time. We won't get to all our topics. And GLP agonists are very much in the news. You picked up on the EPIC research, so always good, because there's significant data. Tell us what we're seeing with those GLP agonists and what the data showed.
Yeah, so we're talking about Ozempic and those kinds of medications. In this case, Epic, and this is a big electronic health record software vendor that we've talked about, that gets their customers to share de-identified data if they so choose, and then puts it all in this very large database. And so, and then what Epic does once or twice a week is kind of puts out a little mini study. It's not peer reviewed. It doesn't have the same force as something coming from a major journal, but at least it's kind of directionally appropriate. And in this case, what they did is they were curious to see what happens when patients are taking, in this case, semaglutide, a GLP-1 agonist, or liraglutide, actually. So taking one of those two medications and then stopping. And that's always been the question, right? With these wonder drugs, they seem to allow you to lose a significant amount of weight. And we've talked previously on the show about some of the benefits of these medications in terms of other things besides weight loss, mostly around urges to do things that we generally would like to stop doing. Anyway, the worry was, well, is this a medicine you have to be on for the rest of your life? If you're taking a cholesterol lowering medication, you're on it. If it's working, you're on it forever. And so were these medications going to be like that? And oh, by the way, these medications are exponentially more expensive, at least right now, than other things that we take forever, like high blood pressure medicines or cholesterol medicines. And I won't bury the lead here. It looks like from some of these preliminary data that actually a lot of people, I'll just say it that way, a lot of people did maintain the weight loss that they had. And so, somewhere around 60% or so either maintained or lost a little bit more weight after they stopped taking the medication. And so, this is only 1 year after discontinuation. And so, or a little bit more, but, we certainly don't have 5 or 10 years of data because these medications have not been around that long. But from a preliminary standpoint, it's pretty reassuring to see that the majority of people, not all people, I mean, we're still talking over a third of people regained some or all of their weight when they stopped taking the medication. But some folks did manage more than not to keep the weight off. And so, interesting study. We'll see as we get more patients. This was with 20,000 patients taking semaglutide and almost 18,000 patients taking liraglutide, which seems like a small number, but it's a big
number. And certainly for studies, as studies go. So that's great news. And I think we've certainly seen the value proposition. There's definitely a cynical side to this. Take a pill, solve a problem. At its core, if it just breaks the cycle, I mean, I think the fairly well-established fact is no matter what weight you are at, your body says this is the perfect weight, and anything you try and do to reduce it, it's going to fight. So if you're at 3x of what you should be, your body's saying, oh my God, this is the best weight, don't ever give up on this. And if this breaks the cycle and allows you to get back down, I think phenomenal. However, as you might expect, not quite all good news. And to your point of the sort of move to this and large numbers, there's an awful lot of heat currently around the gastro or the stomach side effects, nausea, vomiting. There was a case in Australia of a patient who essentially tried into this sort of whole slim down for a daughter's wedding and essentially died. There is now a lawsuit currently undergoing that is identifying these individuals and saying that they downplayed all the gastro effects. But the most striking thing that I saw or read in this was, and I'm going to quote it directly, but this January, gym goers and diet gurus may notice that the usual crowd of New Year's resolutioners has shrunk compared to previous years. I'm going to say, yeah, absolutely. And their supposition, and it hadn't occurred to me. I saw barely any of the crowd that I would fight with to get to the machines and so forth. And it had disappeared, and they're attributing that to the GLP agonists. So I'm not sure that's a good side effect. It definitely, well, actually, no, let's be clear. It's definitely not. Go to the gym instead of taking these things, or actually both maybe, but, a little bit troubling. So interesting whole area. Moving on, let's talk about something we haven't talked about in a while, which is COVID. And I think the major thing here is that COVID continues to impact the world. And let's be clear, both as an active infection that people are having, but also we're seeing this long COVID impact that has been studied, not as extensively as I think needs to, but essentially, is there something to this? And, the findings of this extended study suggest that there are numerous effects of this virus that continue to persist. I don't know about you, but I certainly have friends that have both suffered to a greater or lesser degree recovered, and some who have absolutely not and continue to be essentially incapacitated. One of the most troubling things was that the brain seems to be impacted, and they're seeing cognitive deficits, at an extended period of time, which, as you think about from an age standpoint, I think we saw a tilt towards the elderly. Maybe I don't know if this is going to affect the youngers, but any thoughts?
Yeah, the more we know, the more we don't know. And
By obviosity.
Yeah,
okay,
thank you.
yes.
Thank you very much. Thank you. Don't forget to tip your waiters and waitresses. Listen, for those who think COVID's over, it ain't. And certainly the days of the raging pandemic and hospitals being overrun by COVID patients, many of whom there was no treatment and there was nothing that they could do. We're clearly not there, thank God. And so that's gone. But it's still out there. There are still patients dying from COVID, some of whom are elderly and have other problems, other chronic care problems. So there's really nothing that could have been done. And much like we still have patients who die from the flu every year, like these things are going to happen. However, we have medications like Paxlovid and others that I think are becoming less prescribed, and people are kind of poo-pooing them. Well, it's just like a cold. Well, it's apparently not like a cold for
Right.
a lot of people. And so and you don't want to be one of those few folks, but there's really no way of predicting who's going to be impaired for a long time or forever. And we have not gotten. We're doing. There's a lot of science about why. Why are some patients clearly a minority, but why are some patients who get COVID either had a bad case or maybe not such a bad case, but now they've got all kinds of problems from temperature problems, heart rate, kind of their heart racing, to brain fog and everything else, and trying to come up with one easy to understand way to explain all of that is eluding us now and might elude us forever. And so certainly not getting COVID is a good suggestion. I'm not sure that anyone in the United States probably has not had COVID, even if you think
no
they haven't
COVID
had
virgins
COVID.
is what you're saying.
Yeah. I suspect, I'm sure there are some out there, but even people who think they've never had COVID have probably had COVID.
Yeah.
And so because of the vaccines, because of the medication, because now so many of us have had at least one bout with COVID, we're all out there, but not getting it again is a good idea. It's certainly not the cold. It's certainly much more complicated than that. And so I certainly, when I'm in a large crowd or if I'm on a plane with someone hacking behind me, you can bet that I'm going to have a well-fitting a mask on.
Yeah, you and me both. Actually, there's another good reason to wear one of those masks, because if you've ever been on one of those planes with somebody crop dusting, you want to put that thing on.
Yeah, no matter what, right? Like,
right.
right.
Because that's the best test. If you can't smell stuff, then it's good. So
I've had people kind of look at me and like, it's just a cold, and my response is, and I don't want it. Like,
right.
Why are you telling me it's just I don't care whether you have pneumonia or whatever you have. You have something, and I don't want to get it. And so, thank you very much. I'm gonna pass on your opportunity.
it's the gift that keeps on giving, unfortunately. So
yeah.
So let's finish off, shall we, talking about whole body scans. So good news, you can, for a mere snippet, 2,500 from one of the many emerging companies, get yourself a whole body MRI or full body, whatever they want to call it. And gosh, they can detect 500 conditions apparently. And wow, this is fantastic because they can point to a single patient that saved their life. This is this N of one. And I before I let you loose on this, to me, this is absolutely slick marketing that is fear mongering, and, is essentially selling a resource that should be used appropriately. I mean, to this day, we still have challenges determining whether screening is appropriate or not. And let's talk, for a second, mammography, colonoscopies. I'm not saying don't. That's to be absolutely clear. But the risk reward benefit is not as simple as you might think. And the idea that you spend that money, so let's add to the medical debt. But by the way, and I've seen this personally, you essentially find things that then have to be investigated, the incidentalomas and all the downsides. Terrible, terrible, terrible. It's just, I just don't do it, is what I would say.
Well, wait. Let's not, don't do it in terms of a whole body scan. Yeah. I don't think you're saying don't do routine colonoscopies.
No. Yeah, absolutely. I only use those as examples because everybody's familiar with them and say, hey, we do this, and it makes sense. But it's not quite as simple. I do those. I have my screening and entirely appropriate, but there is a risk balance. But
yeah, absolutely. Yeah.
On the whole body, would you have one?
No. And for exactly why you said, no, it doesn't matter because again, you've got one out of a gazillion where they do find something and treat it and maybe save someone's life. No doubt that's accurate, but a lot more, they're not going to find anything. But a big chunk of those, like you said, an incidental loma, right? Hey, there's this thing and we don't know what it means. We can't really be sure. It might be nothing. It might be deadly. We're going to recommend another test, and then we're going to recommend a biopsy. And then, oh well, you started bleeding, so we had to do. So to your point of, yeah, none of these screening tests are. They all have side effects, and in general, when we talk about things like colonoscopy and mammography and vaccinations and other things, like we know over years and years and years that the benefits outweigh the risks for almost all patients, right? Almost all patients. We don't know that about things like whole body screens, and I suspect if we did have the data, it would show that most of the time it's not showing anything that we can that wouldn't be found through other venues most of the time. But there will always be those stories like there are, that they're advertising where my life was saved by this.
Always find them, but it has to be, and that's the point. Same with, generalized screening has to be clinically driven based on the individual, their particular risk profile, all of those things, age, risk, reward. But this sort of, hey, spend all this money. It's a hard no from me. Unfortunately, we find ourselves at the end of another episode exploring healthcare's mysteries before they became your emergencies. Until next time, I'm Dr. Nick.
And I'm Dr. Craig.